Welcome, everyone. We're going to get started in just a moment. Okay, we're going to go ahead and get started. Welcome, everyone, to today's webinar on understanding opioid use disorder within the LGBTQ community. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, housed at Rutgers School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name's Ann Murphy, and I'm the director of the MHTTC Northeast and Caribbean, and I'll be facilitating the webinar today. I also have with me on the webinar my colleague, Katy Rivera, who will be in the chat box and also addressing any other questions or concerns you might have as we go through the webinar. Next slide. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health and other related workforces to deliver evidence-based and empirically supported practices to individuals with mental illnesses. We encourage you to visit the MHTTC Network website for additional information at mhttcnetwork.org. And then from there, you can search for your center, and we are the Northeastern Caribbean. You can also sign up at the bit.ly link that you see on your screen to receive notifications of our activities, products we develop, and upcoming events. Next slide. Before we begin the webinar, I wanted to quickly review some housekeeping items. Today's webinar is part of a series on affectional and gender diversity. We're coming to the end of our series. We have one more webinar scheduled on addressing blended family and trauma issues with affectional and gender minority parents. And that'll be held on July 28th from 3:30 to 4:30, and you can register for that on our website. Next slide. We also wanted to ask that you complete our very brief survey that you'll receive. Well, you will either be redirected directly from this webinar or receive a link via email following the webinar. It's just a handful of questions. It only takes about 2 minutes to complete, and we value this feedback as we use it to improve our activities and inform future activities. The surveys are also important because our funder utilizes them as one mechanism for seeing what we do and how people respond to what we're doing. So we thank you in advance for your feedback. We did also want to let you know that this webinar is being recorded and will be posted to our website along with the PowerPoint slides. And following the webinar, you'll receive a link to our website where the recording and the PowerPoint slides will reside. This webinar is interactive, so you have on your screen, you have the taskbar that includes a Q&A button and the chat. We encourage you to use the chat function throughout the webinar to comment to your fellow participants, to the panelists, and to the presenter. And if you have questions as we go through the webinar, if you type them in the Q&A or in the chat box, I'll collect them and present them to our presenter at the end during the Q&A. So now we're going to go ahead and begin. With us today, we have our presenter, Dr. Zazzarino. He's an assistant professor at Rutgers University in the Department of Psychiatric Rehabilitation and Counseling Professions, where he's currently a core faculty member and the master's program in rehabilitation counseling and the doctoral program in psychiatric rehabilitation. Additionally, Dr. Anthony Zazzarino is the field experience coordinator for the counselor education and supervision program. Previously, Dr. Zazzarino provided instruction for professional education courses for New Jersey's supported housing agencies, implementing community support services. Dr. Zazzarino actively presents at local, state, national, and international conferences related to affectional and gender minorities, multiculturalism, psychiatric rehabilitation methods, counseling services, housing supports, and supervision practices. In addition to his work at Rutgers University, Dr. Zazzarino continues to conduct clinical work by facilitating group therapy for adolescents and adults at an intensive outpatient program, providing outpatient counseling services at his private practice, and providing clinical supervision for counselors who need supervised clinical hours throughout New Jersey. We're very happy to have him here with us, and I will turn it over to Dr. Zazzarino at this time.
Thank you, Anne, and thank you all for being here again today. For those of you who have previously been on these webinars, like Anne said, this is one in a series. I appreciate you coming back. For those of you who this is your first time, thank you and welcome. And like Anne mentioned, on our website, and if you look at the our YouTube channel, you'll probably find some of the previously recorded webinars. So feel free to go back and take a look and just watch some of the ones that we've done. I've had a really great opportunity, really great experience doing these, and hope that this one is just as interactive and engaging. So thank you all. So today, we're going to begin talking about and highlighting just briefly the difference between sexual, affectional identity and gender identity. And I'll explain very quickly why that term is in parentheses. We're going to describe the implications of opioid use disorder within the LGBTQ+ population, and then discuss best practices for working with the LGBTQ+ who have opioid use disorder. I am going to preface this. Typically, I do recommend, and if you go back and watch one of the webinars about language, really focusing on affectional identity and gender identity separate. Since this is a topic that we're talking about both populations together, I am going to be using the umbrella term of LGBTQ+. However, when we get into it, I'll explain why it really is important to kind of separate them out when you're looking at both groups very distinctively. So today is what, June? I don't even know. We're in Corona land. It's June 30th. Today is the end of National Pride Month 2020. I feel like it is very necessary to just highlight this and you know, give a shout out to National Pride Month for this month. Some of you may know, but Pride Month is an entire month dedicated to uplifting LGBTQ+ voices. It's a celebration of the culture and the support of LGBTQ rights. Throughout the month of June, nationwide, there's traditionally been parades, protests, performances, live theater, and memorials that really celebrate the life of members of the community who not only lost their lives to HIV/AIDS, but continue to struggle on a daily basis with stigma, discrimination, and oppression. It is part political activism, part celebration of all LGBTQ community has achieved over the years. Why do we celebrate in June? Well, we celebrate it to coincide with the catalyst of the gay liberation movement that was the Stonewall Uprising. In the early morning hours of June 28th, 1969, police raided a popular gay bar in New York City's West Village called the Stonewall Inn. This was commonplace for the time, but on this particular evening, the patrons of the bar fought back, starting the Stonewall riots, which went on for days. The Stonewall Inn was declared a historic landmark by the city of New York in 2015 and later named a national monument by President Barack Obama in 2016. So I think it's really important, especially now as we see June coming to a close, to just highlight and bring more awareness to National Pride Month and all that it entails. So thank you for being here to celebrate the end of Pride Month with me. So I previously talked a little bit about the importance of differentiating the terminology and maybe not using the full umbrella term of LGBTQ+. And historically, it's because we oftentimes group two very distinct populations into one. And it's important to recognize that the difference between gender identity and sexual orientation is the difference between who you are and whom you love. So when we're looking at affectional identity, which is a newer term, which is why I have it in parentheses, because it's a term that maybe not so many people are more aware of. It's a term that's currently replacing the idea of sexual identity, because of the word sexual identity really places too much emphasis and the focus is on sex itself. And we all know that the connection between people is much more than that. So I will highlight the definition of affectional identity because it is more, it's a newer term, but we're talking about the direction in which one is predisposed to bond emotionally, physically, sexually, psychologically, and spiritually with another. And then when we talk about gender identity, we're looking at the internal individual sense of gender, so how you identify yourself. So very two distinct and separate concepts. I'm not going too much into depth at all on this slide. Like I said, and I see Dr. Ann Murphy has posted a link to the webinars. There was a full hour-long webinar just on language. And I really do encourage you, if you work with any member that identifies as an affectional minority or gender minority or gender diverse, I think it's important that we use appropriate and adequate language. Not saying that we will be perfect all the time. I will probably mess up at some point in this next hour, and if I do, I will correct myself. And I think that webinar highlights proper ways and proper terms to use, but also proper ways to kind of make a correction if you need to. And same thing here, where we dove into language and gender diversity, and also on that website you'll see one whole webinar strictly devoted to affectional identity and one webinar strictly devoted to gender diversity. So I don't want to go into much detail other to show you this slide and highlight that when we're talking about gender, we need to recognize that gender is much more than just male and female, right? That there is so many different facets of gender and that gender falls on a continuum. And I implore you to go look at that resource. So why is this conversation and this topic one that we're talking about today? I don't think any of you would be surprised that talking about opioid use is something that's important when we're providing services and support to people nowadays because of the prevalence of opioid use disorders. Specifically, members of the LGBTQ+ community have been disproportionately affected by substance use disorders. When I was looking at some research at this, sadly, the research does not hit the current trends in terms of tracking this a little bit better. But in 2015, the National Survey on Drug Use and Health identified that lesbian, gay, bisexual men and women across all age brackets were significantly more likely to have misused prescription pain relievers in the last year compared to heterosexual adults. And that's the slide that you're looking at here. It's really important to look at, and this is a little bit of a dated figure from a resource, so you see the terms like sexual minority and sexual majority. But this is specifically related to lesbian, gay, and bisexual. This has nothing to do with gender or gender identity. And you can see that this darker green bar graph shows how much greater than sexual majority counterparts, how much greater of misusing prescription drugs that lesbian, gay, and bisexual individuals experience. On top of this, this study also found that lesbian, gay, and bisexual individuals almost had 3 times a greater risk of opioid use disorder compared to heterosexual adults. Although little is known about opioid use among transgender and gender diverse individuals, the few studies that do exist have found an elevated prevalence of illicit drug use within this population. I continue to try and track down data specifically on gender diversity and gender identity and substance use, and it's really hard to really piecemeal all of this out, specifically because when researchers are still conducting research, we're still using that umbrella term of LGBTQ and not looking at separate groups of affectional identity and gender diversity. So we'll talk about the need for that later on. It's important just to make sure that we're all on the same common ground and common language in terms of what we're discussing, right? So what are opioids? Opioids are a class of drugs that include the illegal drug heroin, synthetic opioids such as fentanyl, and pain relievers available legally by prescription, such as oxycodone, hydrocodone, codeine, morphine, and many others. I really like this picture here to really give you a sense of the different types of opiates and their level of addiction, right? And some of these we know of and some of these we've heard of. But when we're talking about opioid use disorder, this is what we're grounding all of that in. Also, when we're talking about opioid use disorder, we just need to make sure that we are speaking the language of the DSM-5, the Diagnostic and Statistical Manual of Mental Illnesses, the 5th edition, which really breaks out the criteria for opioid use disorder. I'm not asking anybody to remember this verbatim. I'm not asking people who are not licensed clinicians to go out and diagnose people. It's just more for your own awareness about if somebody has an opioid use disorder, what does that really mean? And these are some of the criteria that clinicians and practitioners use to diagnose. And you can see, depending on the number of symptoms, describes if it's mild, moderate, or severe. If you've been in some of my presentations, this slide is probably familiar to all of you. And it's really important to highlight it here, right, when we're talking about the minority stress. The higher the prevalence of substance use disorders, including opioid use disorder, among the LGBTQ+ population can truly be best understood within the framework of minority stress. So if we think about it, starting at a young age, LGBTQ+ people live with everyday discrimination, marginalization, and victimization based on their affectional and gender identity statuses. So the minority stress model really highlights that stigma associated with minority identity confers additional chronic stress, which contributes to negative health outcomes. And when we are looking at that, we're looking at the external stressors and the internal stressors, coupled with just regular general psychological processes and how that can foster additional mental health needs and mental health problems, and ultimately physical health problems. Why it's so important to highlight this today is because we're going to see that sometimes people start taking opioids just for general physical health problems, and then that could perpetuate into an addiction. Minority stress occurs along this continuum, right, from distal processes known as the enacted stigma, which includes discrimination, victimization, or harassment, to proximal processes, which is known as felt stigma, which includes expecting rejection, concealment or identity, and internalized stigma. The internalization of gender-related stigma through everyday discrimination experiences perpetuates feelings of minority stress, and significantly can lead to worsening psychological health. Development of traumatic stress responses can lead to worsening psychological health, and from multiple acts of discrimination can lead to even greater risk. So it's important to really understand how the fear of oppression and discrimination can lead to different mental health problems. External stigma can become internalized, right? So I start to feel like other people might be looking at me or thinking of me differently, and then I start to feel that myself, leading to identity concealment, self-hate, feelings of worthlessness, and fear of rejection. To escape or to really mute these challenging emotions, some LGBTQ+ people turn to opioids and other substances that provide a sense of euphoria or relief. These behavioral coping mechanisms can lead to worse mental health and physical health problems such as psychological dependence and addiction, depression and other mental health disorders, and HIV and other sexually and intravenously transmitted infectious diseases. This minority stress theory has been proposed as a way to understand the health disparities. So for example, LGBTQ+ youth in particular may turn to opioid use to cope with stigma-related stressors. One study of the youth that really looked at affectional minority youth indicated that they are more likely to initiate opioid misuse early in life compared to sexual majority peers. Other studies have found associations between the stress and higher opioid use among young men who have sex with men, and specifically Black men who have sex with men. A large survey of transgender Americans found that 35% of those who experienced school-related harassment or assault reported using substances to deal with this mistreatment. So when we look down and we try to look at the root of why are LGBTQ+ individuals experiencing higher rates of substance use, specifically opioid use disorder, it really does boil down to this concept of minority stress, the external stigma, the internal stigma. In medical settings, LGBTQ+ people are exposed to opioids at disproportionate rates as well. According to a recent Massachusetts behavioral risk factor surveillance system, 58% of sexual and gender minority, I'll correct myself, 58% of affectional and gender minority respondents between 35 and 44 years of age report ever being prescribed an opiate by a medical professional, compared with just 35% of their affectional and gender majority counterparts. So we're looking at about 23% increase. Certain clinical situations place LGBTQ+ people at increased risks for opioid exposure in medical settings. A really concrete example of this is related to gender affirmation surgery, right? So though we know that not all transgender individuals pursue surgical methods for gender affirmation, the data from the American Society of Plastic Surgeons suggests that gender affirmation surgery is on the rise, as opioid therapy is by far the most common form of post-surgical pain management, and opioid dependence is correlated with frequency of opioid exposure. Each of these procedures places transgender patients at increased risk of developing opioid dependence. So we have to, if we're working with people that identify as transgender and are thinking about the gender affirmation surgery, it's important to recognize and really plan for these things ahead of time, since we already know that this exists and that it's increasing. Additionally, both transgender people and older people living with HIV have increased prevalence of chronic pain and up to 1/5 report taking opioid-based pain medication. Taken together, these clinical situations suggest that certain subpopulations of the LGBTQ+ community are at an increased risk of developing opioid use disorder and signal the need for special care in prescribing opioids. And sometimes we are the voices and the advocates for the people that we provide services for. And it's important to have these conversations not only with the people that we support, but with practitioners and with the doctors to also support our clients. We also know that substance use is known to mediate the relationship between life stress and sexual risk. And opioid use in particular has the potential to increase HIV risk via sexual and injection drug behaviors. So for example, when we talk about non-medical opioid use among men who sleep with men, and I'm very strategic in using that language, men who sleep with men, and I'm not using the term gay men because these are men who might identify as heterosexual, and we know that affectional identity is something that only the person could identify as. So non-medical opioid use among men who sleep with men was associated with increased risk of condomless sexual intercourse, increased number of sexual partners, and sharing syringes. Additionally, we know that opioid use may compromise obtaining and giving sexual consent. And these are all factors that we need to be aware of so we can educate the people that we're providing services to, and as well as educate ourselves. Furthermore, treatment for opioid use disorder has been shown to be associated with reduction in certain high-risk sexual and injection drug behaviors and an increase in condom use, bolstering the case for addressing opioid use disorder in the LGBTQ+ population. So as we continue to address opioid use, we're starting to see, and I'm talking with my hands right now, I'm sorry that you are not seeing this, but as we begin to support opioid use within this population, we're seeing better results related to decrease in condomless sex, decrease in HIV risk, and just fostering greater sense of overall physical and sexual health. So sadly, we know that this population is at a greater risk, right? We know the reasons why. We understand that most of this is related to the minority stress that people are using. How do we support this population? How do we support affectional and gender diverse people who are struggling with opioid use disorder or just struggling with opioids in general? One of the best ways, and this is also what's most prevalent for working with opioid use disorder in affectional and gender majority counterparts, is the medication-assisted therapy plus counseling. Really supporting people and connecting them with all of these resources. Sadly, even though we know that this is the best form of treatment, given the multiple layers and nature of opioid use in the LGBTQ+ population and the complex medical needs of this population, certain concerns and considerations may arise during the course of opioid use disorder treatment. And some of these issues that might arise are really important to have these conversations with our clients to kind of help them process these a little bit more. For example, how will treatment affect adherence to hormone therapy for transgender individuals? How will treatment affect adherence to antiretroviral therapy for affectional and gender minority people living with HIV? And to pre-exposure prophylaxis or PrEP, right, for those who are at risk acquiring HIV. So just like we would have conversations, and I've had these conversations in the past with people who were taking some really strong antipsychotic medications and were hoping to get pregnant, right? Having these conversations ahead of time and talking to the doctor, what would this look like? How could this course of treatment impact my life? These are the same conversations that we need to be having, just from a different outlook, right? How can the medication-assisted therapies, how could that impact already what I'm taking, whether that's PrEP or medication for HIV? And sometimes it's really having those conversations. Well, what's more important? Are there other alternatives? We also look at different ways and different strategies to work with the counseling route. And I think for us, it's getting this awareness so that when we're maybe working with people and trying to refer them for mental health counseling, what are certain questions that we should be asking, right? Who are we looking for to best support individuals who struggle with opioid use disorder and identify as a member of the LGBTQ plus community? We know that already many LGBTQ plus individuals are currently underutilizing counseling services, right? And some of the factors that research highlights that may lead to the underutilization are the negative experience that these individuals feel and encounter. So if we are making a referral, we need to make sure that that referral to a counselor is of a counselor who is aware, educated, and open and accepting to members of the LGBTQ plus community. We also know that lack of counselor and staff competency leads to people underutilizing services. So how do we inquire what kind of education and what kind of competence counselors have regarding this population? And I will say, working in this field, but obtaining my master's degree in a 60-credit master's program, I learned how to work with members of the LGBTQ plus population for 1 week in my multicultural counseling class. In my dissertation research, I did some interviews and had asked some other counselors, well, tell me about your training and your education in working with affectional identity, affectional diverse individuals. And sadly, throughout all of my interviews, I heard a recurring theme of, well, I really didn't get any in grad school, or I got very little. And sadly, we always hear that I had to go seek out this information and this competence on my own. And this is what everybody here is doing. And it would be really important to maybe ask a counselor, if you're helping link or refer a client to a counselor, to say, hey, what kind of training do you have? What kind of workshops have you attended? You know, most social workers and mental health counselors all have to complete continuing education units. It would be empowering, I think, to educate your client to say, hey, have this conversation so we can pick that right fit. And the other thing I think to look for is the affirming environment. I think I talked about affirming environment in maybe both of the other webinars that I've done, but what kind of documentation, what does the documentation look like when you're a new client in a counseling program? What's the language say in the intake form? Do the counselors have a sign or a picture or even a rainbow flag to recognize that affirming environment? And it really is kind of trying to match down and pare down the best counselor-client fit and use that in conjunction with the medication-assisted therapy. So here's actually where I'm going to ask you all, specifically around this question. Are there anything that you have done to try to either yourself be, and to demonstrate that you are an affirming, accepting counselor practitioner, or what do you look for when you're trying to pair clients up with a counselor to make sure that you know that they're affirming? So just take a couple seconds and just input it in the chat box, because I think sometimes in this environment, when we start to see different responses from different participants, we might get some other ideas. So what have you done yourself to demonstrate an open, accepting environment for clients, and or what do you encourage people to look for or to ask when trying to find somebody that's warm and accepting and open? And the way you type it in, thank you, I see a couple responses, is on the bottom. You could just type it in the chat box. And I'll say, I don't know why, typically in June, I see a lot of rainbow flags everywhere, and then July 1st, they tend to come down. I don't know, maybe if I haven't been out as much, but I haven't seen as many rainbow flags. But I'll tell you, I'll say this, and as somebody who identifies as a gay man, seeing that rainbow flag, even though some people think it's not that important, to me, I look at that and I say, okay, there's somebody who at least is aware and is attempting to create a safe space. And I think sometimes that's important. Pronouns on my badge, yes. Pronouns and talking about appropriate language is always really important. Queer imagery, flags, queer language, absolutely. The language that we use is so important. And as you heard, I had to correct myself already, so it's okay if we mess up. It's just about how we correct ourselves and continue to be more aware of using the right words. In public schools, maybe a GSA, a Gay Straight Alliance, rainbow color items, informational booklets. Okay, thank you all. If I asked this question and you thought to yourself, oh man, I don't know what I do, use this time to really think about and hear some suggestions, because I think we know that substance use, and specifically opioid use, is at a much greater rate with the LGBTQ plus populations, and trying to figure out ways to get people to start utilizing services and feel more comfortable utilizing services is really important here. Thank you all. All right. So one of the things that we need to be really mindful of is a more trauma-informed approach. The co-occurrence of substance use disorders, including opioid use disorders, with post-traumatic stress disorder is common in the general population. Having a substance use disorder is associated with increased treatment cost, decreased treatment adherence, and worse physical and mental health outcomes for those with PTSD. Post-traumatic stress can occur as a result of an identifiable traumatic incident, such as sexual violence, assault, other hate crimes, but is also believed to occur after chronic pain, insidious minority stress, which many LGBTQ plus people experience throughout their lives. So now we're starting to see a combination of all different factors here. Oh, thank you. Sorry, I'm looking at this. It's not called Gay Straight Alliances anymore. Thank you so much. Somebody corrected me and said it's called Gender and Sexuality Alliances. That's awesome. Thank you for educating me and educating the group. I haven't been in many schools lately, so thank you for that update. Though substance use is a common avoidance strategy for PTSD, treatment for substance use disorders that also targets trauma and stress is an integrated fashion, has proven acceptable in the community addiction treatment program. So now we're also looking for a counselor that has a more trauma-informed approach. The Substance Abuse and Mental Health Services Administration, or SAMHSA, Center for Trauma-Informed Care, offers really great resources, and I'll show you some resources at the end of this presentation for organizations on best practices for providing trauma-informed care for substance use disorder treatment, which can broadly be applied to LGBTQ plus individuals with opioid use disorder. I will say there is nothing concrete or specific for this population and the intersection with opioid use. However, it really has some has some good generalizations that we can take a look at. And according to SAMHSA, a trauma-informed service organization realizes and recognizes these 5 bullet points here, right? So we realize the widespread impact of trauma and understands the potential paths for recovery. We recognize signs and symptoms of trauma in clients, staff, and others involved in the system. We respond fully by integrating knowledge about trauma into policies, procedures, and practices. We seek to actively promote a sense of safety and resist re-traumatization. And we allow for a trauma-sensitive practice environment. And one of the things that I always think about when I talk about trauma-informed approach is just the space that we're meeting with people. Well, maybe now we don't have to worry about this because many of us are staying 6 feet away, but being more mindful of personal space, right? Being more mindful of coming up from behind a client, you know, being more mindful of maybe tapping somebody on their shoulder to say, hey, I'm here. That could be really triggering, and that's not necessarily a trauma-informed approach, right? So thinking about how physical space and how we can try to be a little bit more trauma sensitive. Several evidence-informed treatments designed to improve post-traumatic stress symptoms are emerging, including models for people living with HIV. Trauma-informed approaches to opioid use disorder among LGBTQ people should incorporate all of these things, as well as education about the connection between trauma and its negative behavioral and physical health outcomes. And all of this, you'll see, I'll share a really good resource related to SAMHSA at the end of this. I'm not going to go through this slide line by line. There is a lot here. It really is just for our own awareness and to keep in mind that we can adapt behavioral health addiction treatments for LGBTQ plus individuals. And it is readable, and when you have this, you'll be able to see. So we know that cognitive behavioral therapy has been shown to improve treatment outcomes for people receiving medical assisted treatments for opioid use disorder. And we also know that cognitive processing therapy has been shown to be effective in treating trauma-based stress disorders. The research really highlights and believes that these frameworks can truly be applied to the LGBTQ plus population with an opioid use disorder that is mediated by post-traumatic stress symptoms, and may be even more effective with certain adaptations. So you can see here on the slide the basic principles and then maybe how to tailor it. And this would be a really good question, again, to ask maybe whoever you're referring or whoever you're supporting. You know, ask the counselor or the social worker, what is your knowledge of this? I often find when I get new intakes, they don't ask me a lot of questions. And I always tell my new clients, I'm asking you questions, but at the same time, you are interviewing me as a counselor to make sure that I'm a good fit for you. And when I was working in the community in a housing agency, I would always, before I made a referral to a counselor or to any kind of behavioral health treatment, would sit down and develop a list of questions with my clients to say, listen, this is what, you know, maybe here's some questions that you should ask the counselor so that you can get a better understanding of who that counselor is for that better fit. In this situation, we look at the idea of how providers really need to start helping patients recognizing the adverse impacts of minority stress, as LGBTQ plus people often attribute these effects to personal failures as opposed to external stressors. You start to see a lot more internalization happening here. Some other strategies for providers really include facilitating emotional awareness, regulation and acceptance, empowering assertive communication, restructuring harmful minority stress, and validating the unique strengths of the LGBTQ+ population. That was one of the slides, if you look in the affectional identity PowerPoint, where we looked at the impact of using a positive psychology approach, because that really grounds and harnesses the strengths of the people that you work with. And then last but not least, fostering supportive relationships with LGBTQ+ community and allies. The other thing that we see, check on time. All right, perfect. Is we're starting to see more and more integration of behavioral health in primary care. I actually just last semester was supervising some faculty members that were providing supervision of a multidisciplinary team. They were working within 6 different primary care settings, and it was a team of a rehabilitation counselor, a social worker, and a nurse. And they were able to provide behavioral health care within this primary care setting as a team. And they were able to meet with some pretty neat clients that would probably otherwise never meet with a counselor or with a behavioral health care team member. So we're starting to see more and more of this happen, not only in New Jersey, but across the country. And I think when it comes to opioid use and within the LGBTQ+ population, it's going to be very helpful. So we see that opioid use disorder and other substance use disorders rarely occur in isolation, right? And this is definitely true within the LGBTQ+ populations. More commonly, these disorders exist within a complex interplay of other mental health problems, polysubstance use disorders, and co-occurring physical health problems. Therefore, and integrated models of behavioral health and primary care services really have emerged as effective, comprehensive programs for addressing these health issues. I'll use my mom for an example, which she always loves when I tell her that I use her for an example, and asks for a cut of my paycheck, but she does not get that. She struggles with anxiety and will get a prescription for Xanax quite regularly. However, my mom has never sought any kind of mental health care. Instead, she goes straight to her primary care doctor. And I often wonder if her primary care doctor had this integrated approach, would she be more likely to maybe speak to a mental health counselor or a social worker? And what we see is most people go to primary care settings more often than mental health settings because of the stigma that's associated with mental health care. So we really see that this integrated primary care, integrating behavioral health with primary care, has some positive outcomes. And it would be helpful, I think, if we're making connections and referrals with our clients, maybe finding a primary care setting that is more of an integrated facility. So we see these 3 overall positive outcomes related to integrating these settings. The first one being an improved experience of care. So the patient experience of care within an integrated behavioral health care program may improve by reducing the stigma of substance use disorders. It also improves an individual's access to behavioral health interventions, substance use disorder treatment, medical care, and has shown to improve health outcomes. It reduces patient care fragmentation and cultural barriers among medical and behavioral health providers, and often offers an opportunity to address opioid use disorders with people currently receiving treatment for other mental and physical health problems. We also see the positive outcome of improved population health. So these integrated health settings within primary care increases the uptake of a variety of universal screening programs and intimate partner violence screening. It also allows for a lot of prevention and early intervention efforts. So it can be structured as an outcome-driven with a focus on quality and performance measures. Related to population health, it can also serve as a tool for collecting mental and physical health outcomes on affectional identity and gender identity in medical settings. And we know the greater the research and the more data we have, this is why the census is so important. The more reporting we have on specific numbers for affectional and gender diverse individuals, potentially the greater the funds we have to support these individuals. And last but not least, it's just a cost savings. You know, and I hate to say it like that, but we all know that that cost savings look really good for certain providers, and this is specifically true within the integrated health facility. So what's next? We know that the opioid epidemic is devastating communities across the United States. Though there isn't a lot of information about the specific burden of opioid epidemic on LGBTQ+ populations, we know that other substance use disorders are disproportionately prevalent in this population, and current data exists to suggest the same is true for opioid use disorders. Minority stress is a likely contributor to this increased burden, and also serves as a helpful framework for understanding and addressing the opioid epidemic within this population. Though medication-assisted therapy with buprenorphine or methadone remain critical to addressing opioid addiction, adaptations of behavioral health interventions to the specific needs of this population will also be as important to curb this epidemic. Still, sadly, there is much more work to do to better characterize this burden of the epidemic and to implement and evaluate the effectiveness of integrated LGBTQ+ focused behavioral health interventions. We need to do a lot more research in this area. Specifically, like I noted earlier, there is very minimal research related to gender identity and gender diversity. Even though there's little research overall, there's a little bit more research when we look at affectional identity and opioid use, but very, very little on gender identity and opioid use. So the more research we get done and the more research we can do will serve to find better and more effective LGBTQ+ specific considerations. So before I get to just a couple minutes for questions and answers, there is this slide here that you're going to get to please take the survey. Like we mentioned, we really appreciate your feedback. And I will come back to this slide in a second, I promise you. Here is the information, and like Kati Rivera had mentioned in the chat, you are going to get a copy of this PowerPoint. So please feel free to check out the website. Please sign up for the bit.ly link. I also saw in the chat there is the link to the YouTube video with some videos. Here is a phone number. There's a Facebook. I mean, there's all, you know, it's 2020. You can contact us many different ways. But please, you know, please contact us. Here are some of the resources that I had mentioned that are really helpful. So specifically, the integration of behavioral health into primary care. If you've never heard of that before, I encourage you to just take a quick look at this resource and learn a little bit more about this, because I think we're going to start to see more and more of it across the country. The SAMHSA website for trauma-informed care, and just some additional references here. So you will get all of that. So with that said, let's see here. We have just a couple minutes. And Kati also posted the brief survey in the chat box. So I do encourage you to just click on that link. It really is a quick survey, and your feedback is definitely definitely welcome. Like Dr. Ann Murphy mentioned earlier, this was the 5th training of the 6 in this series of trainings. I will probably be taking a look at all the feedback and making some edits and continuing to provide additional support in the future. So I thank you again for your time today. And with that, if we have any questions, I will open it up. But if not, thank you again and have a good day.
Dr. Zazarino, we've gotten a couple questions, and I see we have just a couple minutes left. If anybody has a question, now's the time to type it in the chat box. One of the questions we received was, do you know if there's any data available on opioid use disorder in older adults or elder population within the LGBTQ community?
Whoever asked that question, that is a great question. And I'm going to say no, because there's so little research done specifically on opioid use and the LGBTQ plus population. I think to get a better handle of what's really going on, more research has to be conducted focusing on subsets of this population. What's really interesting is we know that the older adult LGBTQ plus population is going to be growing enormously in the next 10 to 15 years. I thought I remember reading something, it was going to grow about 3 to 5%, which is pretty large. And we know that older adults within affectional and gender majority populations struggle with opioid use. So I would assume, not grounded in any research at this time, that older adults who identify as lesbian, gay, bisexual, transgender, or gender diverse will see greater rates of substance use. Perhaps you just made me think about my next research study, though, so thank you.
You'll have to give credit, though. I'll have to look back and see who
I
it
know,
was.
let me know
Yeah.
who it is. That'll be a couple of lines. Thank you to so-and-so, yeah.
So you addressed this throughout, but we had the question early on, and I wonder if you would just maybe in summary, just reiterate why you think the LGBTQ plus community is experiencing opioid use disorder at a higher rate.
You know, it really does go back to experiences of discrimination. I'm just going to go back to this slide. Experiences of discrimination and oppression. And I know when I say that, I know many people think that we are in 2020, and especially many people that I know that, you know, I'm from New Jersey and, you know, from the Northeast, we think that we live in a very liberal society and that acceptance of the LGBTQ plus community is widely spread. Unfortunately, that's not the case. You know, we still see that, I mean, just recently, I think, what was it, a week ago, maybe 10 days ago, if that, the Supreme Court had to make a ruling that you cannot be fired for your affectional or gender identity. Like, in 2020, there was potential that that was possible. And I think, so you have those feelings of discrimination and oppression. You also have a lot of people still internalizing affectional identity and gender minority statuses out of fear of maybe being further discriminated against, or like we talked about in one of the last webinar about the coming out process, related to religion or different communities or fear of being ostracized from family. And when we suppress all of these different feelings and we start to feel ashamed of ourselves, a lot of times that leads to using substances to kind of numb all of that. Because I don't want to deal with all of these feelings and thoughts, so I'll just turn to a substance to kind of mask all of that so I don't have to think about that. So sadly, I think, you know, that is why we see much higher rates.
Thank you so much, Dr. Zazzarino.
You're
Well, we
welcome.
are right at 4:30, so I want to thank all of our participants for their activity here. And thank you for attending. And for those of you who have already completed the evaluation, we're very appreciative of that. As mentioned, you will receive an email from us with a link to the evaluation in case you haven't already completed it, as well as a link to our website where the recording of this webinar, along with Dr. Zazzarino's slides, will be available. And so thank you very much for your attendance. Thank you, Dr. Zazzarino, for a wonderful presentation. And I wish everyone good health and safety and a good rest of the week. So thank you very much. And we will hope to see you again soon.
Thank you.